Welcome to Evidence Mastery. I am Dr. Masood Tusi, and today we are examining the evidence and clinical management of lung carcinoma. Please note, this material is for educational purposes only and does not constitute medical advice. Globally, lung carcinoma is the leading cause of cancer-related death. In 2022 alone, the International Agency for Research on Cancer estimated 2.5 million incident cases and 1.8 million deaths. This map highlights the significant geographic variation in lung cancer incidence. High incidence regions like Australia contrast sharply with low incidence areas like West Africa. These differences, along with a distinct male predominance, are directly tied to regional smoking prevalence and respective levels of economic development. Clinical practice now manages lung cancer as a collection of distinct molecular entities, requiring individualized diagnostic and therapeutic strategies based on a patient's unique genetic profile. The primary etiology of lung cancer is cigarette smoking. Both active and passive exposure account for approximately 85% of all cases, demonstrating a clear dose-response relationship between the intensity of exposure and cancer risk. Risk compounds significantly when patients are exposed to secondary occupational and environmental carcinogens. Chronic inhalation of hazardous materials like asbestos or radioactive gases like household radon independently drive tumor development. Daily exposure to severe air pollution and smoke from primitive, unventilated indoor cooking or heating fires further elevates this risk in developing regions. Yet 15 to 20% of cases occur in patients who have minimally or never smoked. In these individuals, the disease is often driven by pre-existing germline variants, familial aggregation, or chronic inflammatory conditions like chronic obstructive pulmonary disease. Whether the trigger is tobacco smoke, radon gas, or chronic inflammation, these agents must inflict prolonged, repeated insults to the respiratory tissue to initiate the disease process. This accumulation of sequential genetic and epigenetic mutations in respiratory epithelial cells is known as field carcinogenesis. The tissue requires prolonged exposure to these carcinogenic agents before becoming truly neoplastic, dividing abnormally and forming a tumor. This flowchart shows the fundamental clinical classification of lung cancer into two major histological categories. It divides into small cell lung cancer, comprising about 15% of cases, and non-small cell lung cancer, which makes up the remaining 85%, and further branches into adenocarcinoma, squamous cell, and large cell carcinomas. Small cell lung cancer is highly aggressive and occurs almost exclusively in people who smoke. It is driven by nearly universal loss-of-function mutations in tumor suppressor genes like TP53 and RB1, which typically cannot be directly targeted with current therapies. In contrast, non-small cell lung cancer, particularly adenocarcinoma, is frequently driven by oncogenic driver mutations. These are specific genetic alterations, such as mutations in the KRAS, EGFR, and ALK genes that stimulate uncontrolled cell proliferation. Distinguishing between the universal suppressor loss seen in small cell lung cancer and the specific driver mutations of non-small cell lung cancer is the essential first step in modern precision oncology. It dictates exactly which therapies will be viable for the patient. Diagnosing lung carcinoma presents a significant clinical challenge. Approximately 25% of patients are entirely asymptomatic at the time of diagnosis, with their lesions often discovered incidentally during imaging for unrelated issues. This anatomical diagram illustrates how local tumor progression and regional spread manifest clinically. Callouts at the lungs indicate chronic cough and hemoptysis, or coughing up blood. Invasion or compression of the superior vena cava vein results in SVC syndrome, causing facial and upper extremity swelling and plethora. Apical tumors, known as Pancoast tumors, can invade the brachial plexus to cause severe shoulder pain. If the tumor involves the paravertebral sympathetic chain, it causes Horner syndrome, which presents with ipsilateral ptosis, or drooping of the eyelid, and miosis, a constricted pupil. Patients may also present with paraneoplastic syndromes. These are distant systemic symptoms, like hypercalcemia or the syndrome of inappropriate antidiuretic hormone secretion, caused by the tumor secreting hormones or triggering autoantibodies rather than by direct physical metastasis. Because the onset of these symptoms usually correlates with advanced regional or metastatic spread, proactive and highly sensitive diagnostic methodologies are required to catch the disease earlier. The initial diagnostic evaluation often begins with a chest radiograph to identify clearly defined abnormalities, such as multifocal masses or unexplained pleural effusions. However, these findings are only suggestive and cannot definitively diagnose malignancy. If a lesion is highly suspicious, the next step is an integrated PET-CT scan. This imaging combines anatomical data from a CT with functional metabolic imaging from a PET scan, identifying hypermetabolic activity in distant lymph nodes or extrathoracic organs. A definitive diagnosis absolutely requires cytopathological testing. Tissue must be physically sampled from the lesion for strict histological confirmation and molecular characterization. The preferred, minimally invasive method for obtaining this tissue is endobronchial ultrasound, or EBUS. EBUS is a bronchoscopic technique that allows the physician to simultaneously biopsy the primary pulmonary lesion and sample the mediastinal lymph nodes for staging. For non-small cell lung cancer, the disease is assessed using the TNM staging system. This evaluates tumor size, regional lymph node involvement, and the presence of distant metastasis to classify the cancer from stage 1 through stage 4. Small cell lung cancer staging functionally divides into two distinct categories. Limited stage disease is confined to a single hemithorax, managed by a single radiation port, whereas extensive stage disease indicates cancer has spread beyond those boundaries. This rigorous sequence, moving from imaging suspicion to precise tissue biopsy and molecular staging, provides the exact anatomical and genetic blueprint needed to assign the correct treatment. For early-stage non-small cell lung cancer, specifically stages 1 and 2, surgical resection remains the standard curative approach. Procedures like a lobectomy are utilized, provided the patient has adequate preoperative pulmonary reserve to tolerate the loss of lung volume. For patients with limited-stage small cell lung cancer or locally advanced unresectable stage 3 disease, the traditional treatment relies on concurrent chemotherapy combined with radiation therapy. The treatment paradigm for stage 4 disease relies heavily on immune checkpoint inhibitors. These drugs block inhibitory signals like PD-1 and PD-L1, unmasking the cancer cells and allowing the patient's own immune system to recognize and destroy them. This animation demonstrates the mechanics of highly specific targeted therapies. In patients with actionable oncogenic drivers, drugs like osimertinib specifically bind to and deactivate mutated, hyperactive cell surface receptors, effectively halting the intracellular signaling pathway that drives tumor growth. These advancements directly impact prognosis. While the overall survival for small cell lung cancer remains poor, the identification of these targetable mutations has pushed the 5-year overall survival rate for stage 4 non-small cell lung cancer from less than 1% historically to approximately 12% today. The clinical evidence proves that precision medicine and comprehensive molecular profiling are directly responsible for reshaping the historical mortality curve of lung carcinoma. To further improve these survival rates, early detection is critical. The most effective tool for this is annual screening using low-dose computed tomography, or LDCT, which utilizes lower amounts of ionizing radiation than a conventional scan to identify small nodules. This checklist outlines the specific U.S. Preventive Services Task Force screening criteria. Annual LDCT is recommended for adults aged 50 to 80 years old who have a 20-pack-year smoking history and who currently smoke or have quit within the past 15 years. The on-screen primary prevention strategies are essential. These include comprehensive smoking cessation, domestic radon remediation, and the explicit avoidance of beta-carotene supplements in active smokers, which clinical evidence shows actually increases lung cancer risk. While targeted therapeutics offer genuine hope for managing advanced disease, rigorous screening protocols and the elimination of environmental carcinogens remain our most powerful tools for reducing global lung cancer mortality. Thank you for watching Evidence Mastery. If you found this clinical review valuable, please subscribe to the channel and look out for our upcoming book, Real World Medicine, Diseases and Drugs, publishing in 2027.